Here in the 21st century, it's pretty well recognized that tourniquets are safe if used correctly. We only use tourniquets to stop life-threatening bleeding from an extremity. So if it's from an arm or a leg and direct pressure will not stop it, then we use a tourniquet. What's often missing from the conversation about tourniquet application, however, are some of the complications if we improperly apply the tourniquet. We can get the tourniquet too tight, in which we risk causing damage to the nerves, the tissue, and the vascular system underneath where the tourniquet is applied. The complications from a tourniquet that is too tight are not always permanent, however. It can cause complications. It may cause nerve damage and some nerve palsy on that limb. It may be short term, it may be long term, but in the end, if the casualty lives, then those are things that can be dealt with. The other category we'll talk about is if we apply the tourniquet too loosely. Remember, for a tourniquet to be effective, for us to apply it properly, it must stop all the blood flow distal to where the tourniquet is applied, meaning that there should be zero blood flow coming from the heart beyond the point of the tourniquet. From the tourniquet lower on that limb, there should be zero blood flow. If we apply the tourniquet firmly but not tight enough to occlude all blood flow, then we run the risk of actually exacerbating the amount of blood loss or causing compartment syndrome. We'll cover both of these separately. To understand how a tourniquet that is not tight enough can increase the amount of blood loss, we'll use this pork loin as a visual aid. Imagine that this is the casualty's arm. This is where the shoulder's at, so the heart or the trunk is over here. The brachial artery is going to have about 2 or 3 psi of pressure. It's going to rest deeper into the tissue along the bone, and it is what is pushing the oxygenated blood from the heart down the limb to perfuse all the muscles and the tissues of the arm. The veins are going to branch out, and they're closer to the surface, and that's what returns the blood flow to the heart. Generally speaking, if we're talking about life-threatening blood loss, we're talking about an artery has been severed. If we're going to put that tourniquet on tight enough to cause all blood flow to stop, that means we have to get it tight enough so that the artery is pinched, is compressed enough to the point to where the blood has stopped flowing. If, however, we have a deep laceration, but not deep enough to get down to the artery, if it is the veins that are the return system that are closer to the surface, that's not always life-threatening because it has a lower PSI, it requires less pressure, so direct pressure will oftentimes stop venous bleeding. If, however, it is a major bleed, if you have a large vein or several veins that are bleeding profusely, then it can still warrant applying a tourniquet. If you apply the tourniquet and you get it snug but not tight enough to compress the tissue down to the level of where the artery is at, then you have effectively shut off the return flow of blood. The artery, which is deeper, is still pushing and pressurizing the limb below the level of your tourniquet. And then as that blood is attempting to return to the heart through the veins, all of the surface level veins may be clamped down except for the one that is leaking, the one that is severed, or the ones that are severed. So now you have all of the pressure that would normally be diffused through multiple veins returning to the heart. All of those veins are now clamped off and occluded. There's no flow returning to the heart, meaning that all the pressure that is going to that limb is now escaping through that one or the multiple severed veins. So this is how you can actually increase the amount of blood loss, whereas if you had no tourniquet on at all, it would still be bleeding from the laceration, but you would have that pressure also going up through the veins that were not affected by the cut or the laceration. The second issue with a tourniquet that has not completely stopped blood flow is compartment syndrome. For an appreciation of compartment syndrome, it's helpful to understand the anatomy of the muscles. The muscle groups are comprised of multiple smaller muscles. Each of these are enclosed by its own fascia. What we refer to as the silver skin on a pork tenderloin is actually the fascia. That's what encloses the tenderloin muscle within the larger group of loin muscles. So if the pressure builds up within that muscle, there's fluid building up within that fascia. The fascia can only stretch so much, and then it's starting to put pressure internally, having reduced blood flow within that compartment, within the tissues. We start to have tissue necrosis, meaning that the tissue can start to die off. To address compartment syndrome, the surgeon will use their scalpel in the OR and they'll make multiple incisions cutting through the fascia, opening up the muscle to allow it to drain. So now we have an open wound in the hospital that's also prone to secondary infection. Some studies have shown that post-rehab, the patient may not regain full function of that limb, the muscles, once it's all been sliced in 4 cardinal directions to relieve the pressure of each of the compartments or each of the sub-muscles within that muscle group. Now, compartment syndrome is not just associated with tourniquet use. It is most commonly attributed to a broken limb. So if you have a broken bone in an extremity, it's causing damage to the tissue inside the muscle. It can also be caused by blunt force trauma. So if there's trauma to the tissue inside the fascia, pressure builds up and it can lead to compartment syndrome. When we're talking about tourniquet use, some of the studies that I've seen as I researched for this video, they differentiate between tourniquets that were used that had trauma to the extremity and the rate of compartment syndrome just with tourniquets alone. It seems to me that the majority of the compartment syndrome that occurred with a properly applied tourniquet, the compartment syndrome was likely secondary, meaning a result of the injury, not necessarily from the tourniquet. So how can an improperly applied tourniquet contribute to the occurrence of compartment syndrome? There are times when we have to apply a second tourniquet to stop a major bleed. This is more common in the upper leg. If the casualty's thigh has a very large diameter, then remember we have to overmatch that 2 or 3 psi of blood pressure at the level of the femoral artery. So the deeper that femoral artery is within the tissue, the more force we have to generate, and if there's not enough force generated with one tourniquet, we may have to apply a second tourniquet. The current guidelines call for applying the second tourniquet adjacent to the first tourniquet. To visually demonstrate this, we use this piece of red tape to indicate where the major bleed is. We're going to go 2 to 3 inches above the wound, and this is where we're going to apply our first tourniquet. Now remember, most commercial tourniquets are 1.5 inches wide. This is to diffuse the pressure over a little bit wider surface area. Between 1 inch to 1.5 inches is kind of the minimum needed to apply the pressure to clamp off the artery at the depth that the artery is at down by the bone, while also diffusing the pressure so we minimize the risk of causing nerve damage, as we discussed in the beginning, if we get the tourniquet too tight. But there are occasions when 1.5 inches wide and getting the tourniquet as tight as you can will still fail to control the bleeding. You may still have blood loss coming from the injury, or if you get as tight as you can and the blood loss seems to have stopped from the injury, but then you check for a distal pulse, meaning you're checking for the pulse below where the tourniquet is at, and you can still detect a pulse. That means that that artery is not fully clamped off, it's not fully occluded, and you still have blood flow to the extremity. In that case, if there's still bleeding from the wound, or if we still can detect a pulse, the current guidelines call for you to apply a second tourniquet. That second tourniquet needs to be applied immediately adjacent to the first one. By applying the second tourniquet immediately adjacent to the first, where there is no gap between the two, then you have effectively doubled the surface area for that pressure. You've gone from 1.5 inches wide to now 3 inches of surface pressure, with the compression going all the way around the limb, and that tends to apply enough force at the level of the femoral artery to where it will effectively stop the blood flow. You're going to get the second tourniquet adjacent to the first and as tight as possible. If you do not have the two tourniquets adjacent to one another, if, for example, you apply that second tourniquet several inches away from the first, you already failed to fully occlude the blood flow with one 1.5 inch wide band. Now you have a second 1.5 inch wide band just further up the limb. The further up the limb we go, the beefier or the larger the diameter tends to be anyway. So now we're just adding to the likelihood that the second tourniquet is going to fail to also fully occlude that vessel at the depth of the femoral artery down by the bone. So in effect, your first tourniquet that failed to fully stop the bleed, but it has slowed down the blood flow, is serving as a dam of sorts. Your second tourniquet that is not adjacent to the first tourniquet is likely also failing to fully occlude the blood flow, but it is still slowly building up pressure within the space between the two tourniquets. So not only is the casualty likely still suffering from some blood loss from the wound, but now we are causing pressure to build up in the space between the two tourniquets. Hence, as the pressure builds up in the fascia, there is an increasing risk. The longer that this pressure builds up, there's an increasing risk of compartment syndrome. So this is how we can cause further injury if we're improperly applying the tourniquets. Now, just to reinforce, I'm not trying to deter anyone from using a tourniquet when it is clinically indicated. If there is massive amounts of blood loss, if it is life-threatening hemorrhage, somebody is likely going to lose enough blood to cause organs to shut down or lose consciousness, then absolutely apply that tourniquet, but you must apply the tourniquet correctly. It must be 2 to 3 inches above the wound, not on a joint, and you get it as tight as needed to stop all blood flow beyond the point of the tourniquet. If it requires a second tourniquet, we're placing that second tourniquet immediately adjacent to the first tourniquet, preferably going above or higher towards the heart. If we cannot go above the first tourniquet because we've already gone as high as possible initially in that hasty application, then it needs to be adjacent to the first tourniquet and just below it. And then we're going to apply pressure with that second tourniquet until all bleeding from the wound has stopped. And when we check for that distal pulse, we should not detect any pulse below the level of where those tourniquets have been applied. If you're an instructor teaching Stop the Bleed or TCCC, TECC, I would encourage you to include at least an honorable mention in your courses so that your students understand the importance of properly applying a tourniquet. If we get the placement of the tourniquet wrong, then we can be ineffective in stopping the hemorrhage. If we improperly apply the tourniquet, you can cause the complications we've discussed here. But I don't want you to take my word for it. I will post links in the description down below for scholarly journal articles written by people much more qualified to speak intelligently on this than I, as well as the committee of TCCC for the military version and the committee of TECC, Tactical Emergency Casualty Care, for the civilianized version of guidelines for what we're talking about here. You can also check those links down below for any updates from the Committee of TCCC or TECC. All right, if you have any questions or comments, feel free to throw that in the discussion down below. If you're a vascular surgeon, an OR doc, or someone who does this professionally, if there's anything that I misstated in this, then do me a favor. Throw an edification down there, educate me as well as anybody else who's reading the comments, but also throw a link so that we can read the most current research on this. That's what I would especially be interested in. If you have time remaining for more medical skills related educational content, you can check out the playlist over here. And if not, until next time, God bless you and stay safe.